So I think we'll go on and get started. I'm Terry Davis, for those of you that I have not met. I am a professor in the Department of Pediatrics, Medicine, and Feist-Weiller Cancer Center. And for years, I've been studying health communication. And the buzz term is health literacy, how to make our oral communication, our written communication understandable and actionable. And because of that, I was asked to be on this national grant, a PCORI grant, I'll tell you a little bit about, that was on transition of care from hospital to home to clinic or skilled nursing facility. Now, 13 months ago when I got on this, I didn't know beans about this topic. I have since learned a ton, not only reading about it, but being involved in a couple of conference calls a week, but doing focus groups of eight focus groups of patients and caregivers in rural, federally qualified health centers, community clinics in Louisiana. One of the missions and beliefs about PCORI is that you need to involve patients, caregivers, and providers. And so for this talk, I have asked Dr. Greenberg to represent physicians. I'll ask him some questions. Catherine Laborde, who is the director of social work, discharge social work up here, and Becky Caldecott, a patient that I met years ago through Dr. Wolf and Micheline Harthomes, who are long gone. But she teaches medical students, she may have taught you, how to give an exam for patients with rheumatoid arthritis. Also, she helped us develop one of the booklets that we designed for ACP for rheumatoid arthritis, giving us a lot of tips like how you wash your clothes, get your clothes out of the dryer, take your medicines when your hands are not working too good. So I don't have anything to disclose for this talk. So here's what we're going to cover. Why is care transition a national priority? What are the problems at LSU and University Health? What is PCORI and why are they interested in this problem? What do patients and caregivers experience when they go home? You guys, we teach you medical students how to diagnose people, what an optimal treatment plan is, but then the patient is the one that has to do this. And they're the ones who have to finish caring for themselves when they go home and care for themselves the rest of their life. Lessons learned from Medicare focus groups and hospital site visits that we did as a part of this grant, and what's working and nationally from the literature and not working. So, why should you care? Patients and caregivers often experience difficulties when they get home. One of the most common things they experience is confusion with their medicine. 20% of Medicare patients are readmitted within 30 days and 34% are readmitted within 3 months. 1 in 3 be back in the door. Black and Hispanic patients, especially those with congestive heart failure and who've had a heart attack, have higher rates of readmission. ACA or Obamacare created incentives and deterrents to address this. Discharge planning and multifaceted interventions enhance patient outcomes and reduce the admission rate 20 to 40%. In LSU, I learned through Catherine, we're doing some new stuff that sounds very promising. So here's the perfect storm. 39.5 million hospital discharges a year. 20% of patients have an adverse event. Hospital discharge around the country is not standardized. They're loose ends. Pending and post-discharge tests, communication with the primary care provider. What if the patient is not clear about what they need to know and do? What if English is their second language? Poor information we give them at discharge, the quality, the availability of it. Poor preparation for them to go home. Their knowledge of their disease and their treatment plan, meds and appointments, fragmentation. Who is in charge when they leave the hospital? So at LSU, I could get data through July. And we had 1,500 discharges per month, 80 to 90 a day, that's hospital-wide. 200 readmitted within 30 days at 17%, and the goal was 14. Now this looks better than the national average, but this is everybody. PEDS readmission rate is about 6% versus Medicare is about 20%. So all comers at LSU is 17%. So here's some national findings about hospital discharge planning and coordination of care. The problems: lack of uniform implementation of care transition planning on our part. Some hospitals, nobody is responsible for coordinating care. Within hospital discharge plan may be very disjointed, varying by floor, department, provider, duplication of efforts. Catherine is telling me y'all are cleaning that up here at LSU. Lack of protected time or dedicated resources. Do you have a discharge nurse and social worker? Do you have a discharge team? Insufficient administrative buy-in. I don't know where the buy-in, I guess the buy-in is coming, or there. And lack of buy-in from floor nurses. And I'll ask Catherine if she's getting buy-in from the floor nurses. Problem with patient data transfer to subsequent providers. Discharge summaries often lack critical data, not sent to PCPs in a timely fashion. Outpatient clinics unaware of pending test results. Further evaluation never completed. Y'all experienced some of that when you, either on either side of hospitalist or the receiving physician. Readmission rates may reflect poorly managed hospital to home transition. Common consequences: patient gets worse. They have adverse events, 72 adverse events, medicine related. Are your patients clear how to take their medicine? Can they get them? Can they afford them? Etc. Failed follow-up appointments and testing. 1/3 of tests that you expect your patients to get are never done. Excess rehospitalization and emergency room visits. Primary care providers dissatisfied with communication or confusion regarding the handoff. Patient, caregiver, and family dissatisfaction. So, Stephen, from the physician's perspective, what do you see as the problems and what's working currently at LSU?
Well, I think the problems are hugely, to quote Donald Trump, hugely it starts with, does the patient care? Does the patient know? Is the patient capable of knowing? Are the caregivers capable of knowing? Do they care? Is there a home that they're going to? We have lots of people who aren't even going to home. There is no home. Have we done the best we can? Have we explained what the medicines are, how they're used, when they need to be used? Have we made sure the patient can get them? And is that within our power even? When I was in my own practice, it was a little bit different. They hadn't invented hospitalist yet. So I admitted the patient from my office, I admitted them from the emergency room. I took care of them in the hospital. I took care of all the discharge arrangements myself, and I saw them invariably back at the office in a week. And if I needed to see them twice a week for whatever time I did, if I needed to see them once a week or once a month, but there was a different type of relationship than we have now, especially since the advent of hospitalists. It just worked completely different. I think what we do here is kind of the best we can do under rough circumstances. I think we can do better when we work together, but I think the solution isn't necessarily, it may be inventing the wheel, but I'm not good at that. I think we need to look at what's working around the country and try to take standardized measures from there, things that we know work, and not just keep trying things, but pick the things that do work and use them, put them together.
What's your number one frustration about patients that you discharge? Well, or, it doesn't have to.
My number one discharge diagnosis, and the house staff has heard this too many times, is failure to take the pills. That's my frustration. Sometimes it's failure to buy them. Sometimes it's failure to take them. But failure to take the pills is my number one all-time biggest diagnosis, reason for admission.
So this is the gap. Y'all are trained. What pill, what drug to give. And if the patient doesn't take it, it's not going to be effective, and you got to know if they're going to take it, and we're going to talk about that. So, Catherine, what's happening here? We had a great conversation. Catherine was highly recommended by Dr. Marion. So what are we doing at LSU to make discharge better?
Well, I think the biggest thing that everybody's the happiest about is service-based case management. We've gone back to that. We were doing unit-based, and that just didn't work. So,
say what service-based means exactly.
We have a nurse case manager and a social worker who are assigned to different service teams. Med Team 1 has their own duo, Med Team 2, Med Team 3. There's a surgery service line. There's a nephrology service line, and so they meet with those particular doctors every day, or they're supposed to meet with them every day, go through patients, and that way there's the continuity of discharge discussions, discharge plans, hopefully foreseeing any problems or barriers that can be solved before discharge.
Now, is this team, this is a special team that's knowledgeable about the patient's condition, whether it's cancer or heart disease, or tell me how that...
Well, there's a cardiology team, so most of those social workers are going to be pretty familiar with cardiology resources. There's a HEMOC social worker, so they're going to be knowledgeable with different oncology resources, whether it be medications, hospice services, different things that they're going to need for that. So yeah, we try to keep them in a service line where they're going to know those resources.
So residents, are y'all aware of this? Do you talk to this team? When do you talk to them? Talk to them every day?
Everybody should be nodding yes, daily, morning.
So how do they get in contact with you, or do you get in contact with them? How does this communication work? Jay, you got it.
Well, I can make a comment of something that has worked really well, and you all should do, is meet with your team right after patient's admitted. Don't call your case manager or social worker the day of discharge and say arrange all these medicines. You don't give them enough time. But if you look at your patient when they get admitted, how are they paying for their medicines? What kind of coverage do they have? What kind of transportation needs do they have? Then you let your case manager know that day that this patient may be here 3-4 days, but this is what we're going to need at the end. And it works very smoothly there.
We have a discharge planning assessment that we're supposed to do within 48 hours of the working hours. And it's supposed to cover anything from how they get their medicines, transportation, all, who's going to be your caregiver. Do you have home health? Are you on dialysis? Do you have equipment at home? Just run the whole gamut of what they may already have. And then our hopes is, like Dr. Marion said, if we're meeting with you all like we're supposed to be doing on a daily basis, then you're running through those patients on a daily basis. We can inform you of who has what barrier. You can let us know what they're going to need, and in turn we can let you know if that's possible. If not, try to come up with some different alternatives so that, it's not time of discharge and then they need 16 things, none of which they can get because they're unfunded.
So part of this Grand Rounds is to help you realize where patients are and what they need, what we as a healthcare system need to do. It's not just the doctor's responsibility. It's working as a team to deliver this coordination of care. So what's working? What do you think's working? When did y'all start this?
Well, we were doing it a while back, and then we switched to unit-based for a couple of months, and it just didn't work, so we're back to service-based. We just went back, but about a month ago, maybe? Yeah. But, yeah, maybe a couple of weeks ago. But we've done it for a while, so I think everybody here is familiar with what service line-based is. If you're not, let me know. But
For at least 2 or 3 years before we were doing it.
right.
So what do we need to do to improve what we're doing
Probably communication.
with the residents and attendings? So residents, what's your problem with communicating with them? What are the barriers? Are they hard to find, or you're busy? What's going on? know, one of the surveys said they're encouraging physicians to talk. Maybe we should do that here. So what's up? I mean, tell me, talk to me. Are there any problems with contacting the team? Are y'all all students? Surely I haven't seen how long. Is anybody calling the team? You are?
I'm having problems contacting the social workers or the case managers. They're always spreading their info.
Good. So you beat them and they meet with them? Good. I just was curious about, I'll tell you what's going on nationally and what we found out. So why do you need to study this? Well, in the past, and I had a conversation with Stephen yesterday about this, most of the focus has been on utilization and keeping people out of the hospital and not what's most important to patients, caregivers, and providers. Had to do with reimbursement. Current practice does not support continued and coordinated care between hospital, home, and clinic. Successful discharge strategies include teaching by an individual or team, a la Catherine and you guys, with specialized knowledge of the condition, that assume responsibility and was accountable for transition and offered ongoing support. And we'll talk about why that's important. Clear and direct communication of treatment plans and follow-up. So, readiness for hospital discharge. You guys have standard guidelines on when it's safe to discharge somebody, and sometimes that's impacted by reimbursement. The patient and family caregiver perspective may be a little different about how prepared they are and what they sense is their ability to care for themselves, their confidence, and their desire for home recovery and care. So the ACP, the American College of Physicians perspective is they recognize that patients are discharged in an intermediate rather than a latter stage of recovery. Discharge assessment should extend beyond criteria for physiological status to conscious declarations of patient capacity, ability, availability, and accessibility of family caregivers and community support. Stephen, you want to say something about that?
I think the third-party payers need to read that and decide if we can do that. Because the reason it evolved to discharging people at the level of readiness, it was driven by third parties, wasn't driven by physicians. We've now all been raised in it for the last 25 or 30 years, but it was not driven by physicians. The mantra has been, if a service can be done in a place of lesser intensity or lesser cost, it should be. It doesn't say the patient's ready. And so I think the third parties have to get on board, or I don't think our hospital administrations will be on board unless the payers are.
So Becky, did you have any problems as, Becky, tell them, why are you qualified to be a patient besides you have RA? When have you been in the hospital the last 5 years?
Well, I've had a stroke. I've had open heart surgery. I guess that's all in the last 2 years. In the last 2 years.
Okay. And you were hospitalized at Willis Knight?
Yes.
Okay.
Yes.
And then previously you cared for your husband?
Right.
And your parents?
Yes.
And why were they in the hospital?
A lot of different reasons. My dad had congestive heart failure, and so did my mother. She also had several strokes, had myasthenia gravis, which entailed a lot of other things, like fluid accumulation and things like that. She also had surgery and had to have an ostomy. Dad, mainly the problems with him were at the last mental, but they were both in and out of the hospital all the time.
And your husband?
Husband had diabetes and cancer, and he had colorectal cancer, which required an ostomy. He had lung cancer, which was managed very well. They were able to remove that spot without having him take chemotherapy or radiation. Now, the colorectal, he had to have the radiation and the chemotherapy. Took care of him through all of that, and then at the last, he had a stroke, a major stroke.
So what was it like going home? Yourself, or were you a widow when you had the stroke and the
Yes.
open heart surgery?
Yes. Well, I had the surgery while he was still in the hospital from the stroke. I had a heart attack. 2 days later, he had a stroke. And so he stayed in the hospital that whole time. I had the open heart surgery while he was in the hospital. So when I went home, I did go home, well, not really alone. I had friends who came in to help me.
What are some things that maybe the residents don't think about? I mean, they are clear about what all this diagnosis is and what treatment plans might be and what they do up here for those problems.
Well, with me, I've been really fortunate. Well, all of us have been fortunate, but one thing that happened to me was when they sent me home after the open heart surgery, I had all these instructions, mainly be sure and hold the pillow to your chest, don't use your arms to push up and everything. But the last thing they told me was, I said, well, what can I do? And they said, anything you feel like doing, if you feel like doing. So I took them at their word. And about the second time that the home health nurse came out, she pulled my friend who was acting as a caregiver aside and said, she's doing too much. You're going to have to slow her down. This is dangerous. But I felt fine, and I, in my mind, thought if I did more, I'd get better sooner, which was not necessarily the truth.
So that was a kind of a vague communication, do all that you feel like doing, and so you're not clear what the limits are.
All the rest of the instructions, beautiful. With my mother, having had so much illness, she wasn't thinking clearly in the hospital and just had no idea what it amounted to have an ostomy. It was supposed to be temporary. I had been up to the hospital and I got home and got a call from this one of the floor nurses, and she said, somebody has got to get up here. She has no idea what we're talking about, and somebody's got to come learn how to take care of this. And so I was the only one there, and I thought, I don't know whether I could do this or not. And I got up there, and there was this was a very good example to me. This lovely ostomy nurse, and she took me in and sat me down and said, this is what you're going to have to learn to do. She walked me through. We changed it out 2 or 3 times, put new ones on, and then she gave me a card. Little did she know that was a mistake, because I was going to be calling her number frequently. When things went wrong, I'd call, and she was Johnny on the spot to tell me what to do, what kind of ointment to get, because she was allergic to the tape, or it wouldn't stay on. And of course, it's all improved a lot since then. It even improved between hers and Joe's. It was much improved. But I got a lot of help, which I desperately needed.
So, and then you had a number to call, and she
I had a
responded.
number to call, and if she wasn't there, she got back with me very quickly.
Great.
So here's one of the reasons that patients don't assimilate information besides like your mother. I modified this from the literature and focus groups that were done at Cincinnati Children's Hospital with parents. A lot of them had low literacy. They're in a fog. When you come in here, you forget what day it is, what time, you feel mentally exhausted. Trouble processing and acting on information. Patients may be reluctant to ask questions because they They perceive a lack of time. Can you hear me without this? They perceive that you don't have any time. There's lack of continuity in the staff, different doctors, different days. Y'all are on a week on, 2 weeks on. If they're here, they discharge not when you're getting here, or admitted not when you're coming on. They might see different residents, different attendings, different subspecialists. Lack of continuity in staff, or feeling they've already been told the information. What information I wish I have? Patients and providers may have different perceptions of what's important. Patients wanted details on red flags, how to manage recovery, want providers to be clear and use consistent terms. Am I ready to go home? Patients' confidence and expectations about their ability to perform care activities and cope with changes, handling uncertainty, may not be in sync with the providers, and sometimes the residents may not be aware of all the stuff they've got to do at home. I'm home, now what? Fear that lack of training and knowledge about care would lead to harming their loved one. I heard this all the time. I'm afraid I'm going to mess up and hurt them or kill them. Too much medicine, not enough medicine, doing the ostomy wrong, whatever. There was a fear that they were really going to hurt their loved one. And then who do I call? So here's some common patient experience with follow-up updates and tests. I feel like different people I was seeing for my care were not communicating with each other. It seemed people did not really care about me as a person. I was treated more like a number. I feel like I really needed to talk to a health professional, but I didn't know who to call. I went to a doctor or nurse or technician who didn't seem to understand my healthcare needs. I went to a test or appointment and found out they didn't have much knowledge about the health condition I had. I had difficulty getting the care I thought I needed. I had to explain my health condition every time I saw somebody new. I felt downhearted and blue. So the ACP, along with the American Academy of Pediatrics, family physicians, and ASCO, have come together, and they say little work is focused on improving coordination of care. Timely information should be exchanged between providers and sites of care. At every point, patient needs to know who is responsible for their care and how to contact them. So I'm not clear if our patients, when they get out, know who to call. Do they call their primary care doctor? Do they call back up here? Do they call Catherine? Personal clinician, and it doesn't have to be a doctor, accountable for ensuring patients of all ages experience effective transition and timely exchange of communication. And I love this. From the patient perspective, nothing about me without me. Shared decision making. So, what is PCORI and why were they interested in this? PCORI is a national funding, like the NIH, and it came out of 2010 with Obamacare. And so what's new about this research, it's very patient-centered. And it addresses questions that are relevant, most relevant to patients, physicians, and healthcare decision makers. So the goal is to move clinical research from the bookshelf to actual use. Imagine that. So engage in a wide variety of stakeholders to make clinical research more useful to society and change how care is delivered. It's huge. They're talking about a shift in healthcare delivery. Premise, research is more likely to actually improve patient care. Patients, providers, and other key stakeholders, and not just researchers, are involved in all aspects of it. PCORI identifies key critical questions in healthcare today in America, and care transition was a priority. Funding began in 2013. To date, $289 million for 162 investigator-initiated projects. They got to go to Congress again next year to justify their work and prove they got a return on investment, that something is actually happening. So stakeholders must be involved in every part of the research. That's in part because I invited all the stakeholders to participate in this instead of me just saying, here's what I learned from listening to caregivers, providers, and patients in the literature. So what's from the horse's mouth? Care transition is a priority for PCORA. They funded 13 projects for $64 million. So Becky and I are involved with Project Achieve, which came out of the University of Kentucky, UPenn, BU, Kaiser, Telegen, people from all over the United States, nurses, doctors, and then they wanted patients and caregivers. I was on as a communication expert. And what they want to do is identify the services, like Stephen was saying, and outcomes most important to patients, caregivers, and providers, determine which services are most effective, lead to the best outcomes, identify barriers and facilitators, and develop recommendations for national dissemination. I'll tell you what we found so far in the first year. So those are the partners. We reviewed the literature, identified key transition of care components. We conducted 40 focus groups. We had to do IRBs in all of these places. 50 hospital visits. We talked to doctors, nurses, CEOs, social workers. Developed and administered survey to 12,000 patients nationally from 40 hospitals, 7,000 caregivers, and 3,000 providers. Determine best practices that lead to desired outcomes and figure out how to disseminate it. So I want to tell you a little bit about the focus groups. It was like a Noah's Ark of focus groups. I did focus groups, Connie Arnold and I did focus groups in rural areas. We went down to Franklin, Louisiana, low SES. We did David Raines. These are federally qualified health centers in Louisiana. Many of these people had low health literacy. They were English speaking. Many of them were dual eligible. The patients had to be 65 and discharged within the last 90 days, or they could be dual eligible and be younger. Other people in Boston did mental health patients, cognitively impaired patients, multiple chronic conditions. So we're about half black and white. Interesting, caregivers tend to be female, and the patients were split. And we recorded and transcribed them, and I'll give you some of the actual patient's voice. So what's important to patients and caregivers? Here's some common themes. Compassionate, this sounds like Jay Marion, compassionate, supportive communication. Anticipation of needs at home, transportation, medicine, equipment, follow-up services. Who's responsible for what? Shared decision-making. Coordination of care to foster continuity. Coordination between providers, access to timely follow-up appointments, and trust. Trust is huge with patients. Patients need to trust you, feel like they are known and cared for. So here's some things we learned from the Louisiana focus group. Relationship with providers was important. Continuity and trust are key. Patients felt connected to their PCPs and had confidence in them. Didn't feel like the hospital staff knew them, their health history. They were less inclined to have confidence in you guys or trust your treatment plan. Doctor never spent enough time with me in the hospital. They don't know anything about my body. Physicians at the hospital are always different with each admission. No continuity of care. You didn't see a familiar face. You don't know anybody. They don't know me. They don't know anything about me. Caregiver concerns. Not being in the room the 5 minutes the physician's in the room. And then the patient may not be clear, a la your mother, about what the provider has said or remembered it. Caregiver felt care slipped when they were not present in the hospital. So patient advice is have someone in the hospital with you to look after you and in case you miss anything. You can't grasp everything they're telling you. You're sick and you're going to miss a lot. So complaints about medication. Many patients got put on different medicines, sometimes all different medicines in the hospital. They take you off everything your PCP put you on. Remember I said they trust the PCP and their treatment plan. Now the hospital treatment plan might be better and more up to date, but do they believe in it and are they going to do it? Many were not clear about what each medicine was for or how to take it. When they give you medicine, they don't explain them. The insurance company sometimes won't pay for the medicines you put them on. Nobody asks if you can afford them. Difficulty getting medicines needed at home in a timely manner. Pharmacy reported they hadn't received the fax, even though the hospital reported faxing the prescriptions before the patient was discharged. Caregivers frustrated with the timeliness of being able to pick up the prescriptions after the patients were discharged. So in the small town in Franklin, the pharmacy closed at 9 o'clock. What if the patient didn't get home from hospital in Opelousas to after 9 o'clock? Here's some bottom lines. Caregiver and patient perspective of what you tell them might be different. Caregivers sometimes remember details of discharge differently from the patient. Patient hears what they want to hear and gets mixed up at home. Most patients were confused when they left the hospital. Several didn't feel like they knew how to take care of themselves. I was not clear about what was wrong with me or what I needed to do about it. They give you a big piece of paper of everything they did to you for you to take back to your doctor. Hospital follow-up calls. Caregivers recommended include the caregiver when the hospital calls. I found out that LSU University Health calls, but they're really checking to see your satisfaction with the nursing care, not how's it going, you have any problems with your ostomy, what problems are you having with your medication. And the caregiver said include them because many patients say everything's fine, and the caregiver can give you a whole different story. Also, when the hospital calls, most patients have a cell phone, and so it's hard to conference in or plan. The caregiver may be working, so you got to figure out how you're going to do that. Home visits. Many patients didn't want home health care and didn't want a home visit. They didn't want anybody in their house. Caregivers appreciated it because it was very helpful to them. Patients expected adequate ongoing support from their family. So we've talked to Becky, and here's what patients and caregivers report about communication. It can be transparent, actionable. Remember, they're the ones that got to act on it. Empathetic, respectful, timely, collaborative, or purposeful. But it can also be frustrating, unpredictable, conflicting. Are we given different messages? Condescending, unilateral, and hurried. So what makes it good? This sounds like Jay Marion again. Supportive, empathetic. Providing emotional support and empathy, this is interesting, fosters trust in the team and in the care plan. Providers who sit down and are not rushed or give the perception, you got a lot to do, of not being rushed. Collaborative, sense of being included and involved in the medical decision making, encouraged to talk, permitted and comfortable asking questions. So I love this, and I would hope it would be one of our internal medicine doctors. The doctor who was leading the internal medicine team encouraged me to talk. This is a patient's voice. When she was in there with the students, encouraged me to talk to the students and to her. You know, she wanted my input on what they were discussing and what was going on, and it made me feel empowered in terms of my health care. Most doctors don't encourage that. They just want to come in there and tell you what they need to tell you, and they want to leave, and they're done with you. But you know, she wanted to talk, she wanted to listen. You know, she fostered a good environment to be able to speak. So what's the difference in how this patient is feeling about her care when somebody just comes in and they're through with you? Caregiver, I think the doctor really just assuring us that it was normal for a person her age to have that type of reaction to a UTI. You know, just explaining how it's an infection. And that initially helped put me at ease, because having my mother talk about my dead father, if he's still alive, was very disconcerting, and I didn't know what to think. So patients, you see things all the time, but they may be very new to patients or caregivers and very disconcerting. Purposeful and supportive communication. Why are you telling them this? Giving them information on what's wrong with them, their test results in an understandable way, their treatment, their discharge plan, education and instructions, medication, wound care, follow-up care, expectations for caregiver needs, giving information about potential side effects and pain and how to manage it, giving timely, predictable information. And you don't know if they've understood you unless you use teach-back to confirm understanding. When I was discharged from having open heart surgery at the Cleveland Clinic, I was given this gooshed list of medicines, And it was very hurried. There was no indication for any of the medicines or how long I was to, or the duration of how long I was to take them. It was challenging for me when I got home. The other thing was I'd never been sick before I had this mitral valve repair. And so all of a sudden, every symptom, every sign, I thought I had snakes in my head. You know, I didn't know what it meant. Before, I'd just say, oh, that's an ache, that's a pain, I'm a little tired. And I didn't know how to interpret it. And I think that's true with many patients. So, clear communication's important. The doctors will say something, and then the person or the caretaker or the patient or whoever will just sit there and go, okay, okay. And then when they get home, they're like, what did they say? What were they talking about? I don't understand that. Many patients or caregivers are afraid to ask, don't know what to ask. Speak to me in layman's terms, bring it down to my level. It's new, you got a lot of vocabulary other people don't have. So teach back is helpful, and this is an example of a nurse going over medicine with a patient. The nurse would go over the medicines, always the whole list. Even what I had at home, the nurse asked, do you take this still? How do you take it? Do you know the dosage? Do you need refills? How many times a day do you take this one or that one? The whole schmeal. They were kind of assessing whether I knew. The nurse at the Cleveland Clinic didn't ask any of those questions. So collaborative communication, and that's really important to the family caregiver, to be included in the history taking and the discharge planning. What to expect when you get home. As Stephen said, they're midway through recovery, they're not recovered. So, and elicit their expertise about what they've got to do. So they could have told us more specifically what to expect with outpatient ECT treatments. They couldn't give us a phone number of somebody to call in the ECT department to get any questions answered. The lack of communication with the family with me was just astounding. They could told me what their observations were about Jim's mental state, their observations about his improvement. All they ever said to me was when I asked them the question, did they think he was getting better? They said yes. It didn't strike me as quite enough. I always felt though I was getting in their way. I was being blown off when I asked them questions. I wasn't getting any information about what I could do, so I wasn't ready to take him home. For me, it was confusing. No medical experience. Didn't know what medical care was going to be. First thing I was observing was a case management nurse had made all the decisions without my knowledge. So I'm under the impression she, the mother, is going to a skilled nursing rehab facility. I didn't have time to go on the internet to do research because, see, I'm working an 8-hour job too. I was totally in the dark about what to expect. You actually just go into it out of love. But at the same time, you're disorganized, you're confused, you feel displaced. You really don't know what to do or what to expect. So this is the context of what's happening with many patients and caregivers. Also, there was a huge problem nationally with conflicting or unclear information, all of us using inconsistent terms. Also, not everybody has a competent caregiver at home that's available. They may be working 8-hour job somewhere else. Anticipating needs, what do they need to do at home, and what about transportation, medication, arranging follow-up care, supplies and equipment? So I love this. Obviously this guy's from Boston or Philadelphia. It's about transportation. See, everyone thinks I have people waiting around in cars or I drive, that it seems I haven't driven since '76 and all my friends are workaholics, and getting them to tear themselves away from anything for more than 5 seconds is almost impossible. I had a hell of a time with the doctors, like I'm supposed to have somebody take me home after surgeries, but I don't have anybody. So they were doing all this trick stuff to keep from putting me under. So part of that is if transportation is a huge problem, and I don't have to tell y'all that. Many of our patients live in rural communities. There's no train into Shreveport. How do they get here? Can they come back for a follow-up appointment? Anticipating needs, what's most important? Feeling safe, supported, confident, and prepared at discharge. Need providers to prognosticate possible challenges, side effects and complications, clear plan of action, anticipate needs about getting the medicine, and anticipating needs set patients and caregivers up for more success. There's so many things, I love this, there's so many things you don't realize that you're not gonna know until you're in the moment of not knowing. In the hospital, I ask 100 questions so you feel like, okay, I must have everything I know. And it's not until you get in the wilderness at home that you realize, oh my gosh, this isn't working so well. It's that person in the middle that notices what you're gonna need, or comes to the house and says, how are you doing with this? I think it's also after the hospital that you end up discovering the vastness of what you don't know. It's so many little things about, where am I gonna sleep? What if I can't get up the steps? So these are daily problems that maybe we don't anticipate patients having. So bottom lines, clear communication, education, accessible phone number. Who's in charge of their care? Who do they call? Can they get them on the phone? And arranging before discharge, follow-up care services, transportation, supplies, training in medical care skills. So I'll tell you real quickly about what we found out when we went to the hospitals. We talked to all the chiefs, the chief operating officer, medical officer, nursing officer, financial officer, operating officer. We talked to the director of case management, the social worker, the quality director, and the physicians, pharmacists, physicians, nurse manager, inpatient nursing, community partners, patients, and families. So here's some bullets from healthcare providers. Communication between departments is key. We believe in talking to each other. That's why we do huddles rather than simple notes or emails. We expect physicians to talk. We push against people's natural tendency to silo. Coordination, strong partnerships with community providers. We should never discharge our patients, just transition them to the next care site. Discharge summaries are too long, too much information. They keep cutting and pasting the notes, and it's not very concise. It's very difficult when the patient has seen 3 or 4 doctors. Efficient management. Ensure all providers, pharmacies, etc. have electronic health record that they're using. Data sharing creates culture of transparency, but some providers said, it seems technology is not working for us, but against us. So you may feel that way too. Patient education. This is what Dr. Marion or Dr. Greenberg were saying. Ideally, they receive education on admission prior to discharge and after discharge. When a patient is discharged, everyone comes to the bedside trying to educate them. Spread the education over 3 days, not in the last 3 hours. Education can bunch up at the end, so we try to educate from the beginning. Shortened stays mean trying to fit in patient education and get a lot of reinforcement. Patient forget. Involve the patient and the caregiver. It's a priority that patients have a voice. It's key to elicit and listen to their goals and repeat them back. The instinct is to do for patients. Instead, we need to help them be able to do for themselves. One of the things most patients will notice is that somebody listens to them and cares for them. That seems to matter most. So here quickly is out of Boston University, Project RED. And so they designed this discharge system. They were going to educate, a nurse educator would educate with an individual instruction booklet, I'll show to you, arrange follow-up appointments, confirm medication reconciliation, but it took 90 minutes. And so I was given a talk a couple of years ago when Project RED came out to Ochsner, and they said there's no way they'll let a nurse have 90 minutes to plan the discharge. 45 minutes with the patient and 45 minutes with the electronic medical record, communication with the team, preparing the booklet. Then the clinical pharmacist calls the patients 2 to 4 days after discharge to review the meds and reinforce the medicine discharge plan. Average total time, 26 minutes per patient, about 20 minutes of counseling. 65% of patients had at least one medication problem. So here was their medicine. What time of day do I take this? Why am I taking this? The medicine name. How many do I take? How do I take this medicine? My discharge instructions, I should have put them up here, were all scrunched together and they didn't mean a whole lot. And then this is the follow-up appointments. So this is who you see on the 8th, what kind of doctor they are, where they are, why you're going there, and what their phone number is. So when the pharmacists call, 15% of the patients didn't think they needed the medicine. 17% didn't fill it due to cost. 11% never picked it up. 12% never got the prescription. 11% discontinued due to side effects, or didn't fill it because of insurance. And incorrect administration was mostly wrong frequency or interval, wrong dose on prescription. Overall, 51% of patients that they discharged at BU had a medication error within 2 days. You think that's typical here? That high? So then they did a randomized controlled trial with about 750 patients. Half of them, they sound like our patients, half of them had low literacy, 50% were African American, and they had red discharge plan versus standard. And so if you got the red plan, you had 30% lower hospital use, 30% more likely to follow up with your primary care provider, and 34% lower cost. So what about the fidelity? How well did they do this? They scheduled the appointment most of the time, after hospital care plan given most of the time, summary fax to the PCP most of the time, and pharmacy completed call 60% of the time. So this just says that more people that got Project Red, 62%, followed up with their primary care provider, were able to identify their diagnosis, were less likely to be readmitted or come to the emergency room. So here are my bottom lines. Care needs to be coordinated to foster continuity. Quality discharge teaching and personal follow-up are key to effective transition. Residents include the caregiver when you're talking. Remember, the patient is sort of in a fog. The caregiver may be in a fog, but 4 ears are better than 2. Supportive, empathic, transparent, purposeful communication fosters transition of care and trust in the team and what you're saying. Anticipation of home needs are important. Decision making needs to be shared. Nothing about me without me. Feeling prepared, confident, safe, and supported at discharge is important for patients and their family caregivers. So what questions do you have about what you as a physician could do? Part of this is a health system plan, but each of us have a role. Yes?
One thing I would emphasize, and anyone who works in university health know about the automatic substitution by the pharmacy. When a patient comes in on any ACE inhibitor, they're going to be put on the lisinopril in the hospital in an equivalent dose. So when you go to discharge them, they've got a prescription of enalapril at home, but they've been getting lisinopril in the hospital. What do? You have to reconcile what they came in on and what they're going home on. Usually you can send them home on the medicine they already have at home. Sometimes there may be a reason that the medicine in the hospital was better, but you need to explain it to the patient, or they have 2 prils at home. Do they take one, do they take both, or do they take neither? A lot of it is cost saving for the pharmacy in the hospital, but some is not. For example, is the only statin in the hospital still rosuvastatin? Okay, so a patient comes in on generic simvastatin that they can afford. In the hospital, they get put on rosuvastatin. Well, maybe they don't need something that potent and they can go home on the simvastatin. Maybe they do need the rosuvastatin. So you've got to look at all those automatic substitutions.
That's a great point, because the hospital has their plan to save as much money and institutionalize it, but it may not fit for the patient, and it may unintentionally confuse the patient.
And another comment that you all have to remember is you use 2 words over and over, anticipate and advocate, basically. Many times we have patients getting ready to go home that have seen a bunch of consultants, and it's at the last minute if we think about it, we decide, oh, you've got this wound dressing that needs to be changed, or you need some sutures or staples out, and then you call the team and they can't answer, so patients, if they're lucky, go home not knowing the answer, but at least knowing that they've got something they need to do. But I've seen doctors get ready to discharge patients that have drains in, and when I said, what instructions did you give them? Oh, I didn't give them any, I assumed that the surgeon gave it. Don't make assumptions. You know, you have to call the surgeon, you ask the patient, do you know what to do, how to advance that drain? No, nobody's taught me. Or we send patients home on sub-Q medications. We've never thought about somebody training them how to give a sub-Q medication. Those are all things that if you're an advocate for your patient and you anticipate what they're going to run into, you start working on it early.
Right, and then the only way you're gonna know that the patient can do that is if they tell you back and show you back that they can do it. But that's gonna take somebody some time. It's probably the discharge team, because the doctor doesn't always have all the time, but somebody up here needs to be on top of that to anticipate the needs and make sure they feel supported going home.
I think one of the best things to do is make sure they have a phone number that they can call and that somebody gets back to them immediately. And then some of the stuff that you've screwed up and not told them before they leave the hospital, you can catch it early when it's not going to be a problem, and your patient will think better of you. So that phone number that the patient or the caregiver can give you to call back about little things is really, really important to the patient.
I think that's really key, because you're lost, you're confused, you're scared. Who do you call? You saw a jillion doctors. Is there one person that you could call? And I gave a talk to nurses in Louisville one time, cancer nurses, and they had the phone number and the name of somebody they could call and responded to them. And that is really reassuring. Becky was saying that, calling that nurse, having her phone number and having her answer you is a lifeline, because you're still sick and need a lot of care often when you go home. Does the panel have any parting comments? Dr. Greenberg, anything residents, and Catherine, anything residents need to know?
Yeah, we need concierge medicine, because that seems to me the only way we're going to be able to achieve this rapidly. And I don't think we have it. As you were told at Ochsner, who's going to pay for 90 minutes of nurse time per discharge? We don't have that many nurses in the building at any given time to achieve that in the course of a day. So I don't know how to achieve it. I agree, these are what needs to be done. I think we're going to have to find some innovative ways to achieve it, though.
Right, a nurse and a doctor are expensive employees. And they have limited time, and we have fewer and fewer nurses. Catherine, any final comments?
I can't think of any.
Becky?
I can't think of any. It's just that you got an awfully hard job and you do have a little bit of time. But I personally, as a patient, think you're going to handle it.
Remember your grandmother patient, yes.
I feel like when we're trying to get discharges, obviously we want to see them in like a week or two. As residents, we're already completely booked, and there's no like ability to bump somebody back or be like, hey, this is higher priority, fit this person in instead of this person. I can see that person in like a couple weeks or a week. And then that patient that just got discharged goes to somebody that doesn't know anything.
Right, you can hear, I went to somebody, they really weren't familiar with my condition or what had happened in the hospital. They need to see you back, ideally.
Yeah. And so I was just calling overbooked myself, but then I got in trouble for doing that. So I think there should be something that just bounce patients. Like if I've never seen the patient before, that person could go see somebody else. This person I know, put them in the clinic.
I think that's an excellent point. Any other comments? Because you got some people here who may be in a position to change things. Some leadership in the room if they have any power. But that, they need to be able to come back to you. The continuity of care is huge. You have a comment?
I think to echo a few people that said something about the heart failure. It's a great example of this, how involved the patient, the family, the caregiver, the physician are involved in the CHF discharge instruction, and that really makes a big impact on their recurrent admission, and their long-term outcome. You weigh yourself, how much salt you eat, whether you're taking Lasix properly or not. And I have seen a few examples where a patient is discharged with 60 milligram of Lasix, but at home was taking 20, goes home and take 20 again, and back to the hospital 2 or 3 days later. So that's very important, and that's where I think we need to put some effort.
I think that's a good point. When I was discharged, I had Lasix, and it said, take something for 14 days as needed. Well, nobody told me how to assess if I needed it. And I just didn't know that, even though I've been on the faculty up here for 27 years. Knew I was losing weight, but, that's all I knew. Well, you guys, Stephen, let's come.
One thing I've never seen here, you have it at the VA, and I lived through this with my mother who had recurrent heart failure, is remote monitoring. And so patients can get on the scale, it's hooked up to the telephone system, and someone, again, it takes resources, is monitoring the vital signs, is monitoring the daily weight with the patient.
Yeah, it's only half done when we've discharged them. They got a lot to do when they get home. So do good work.